Hello, I'm Luis Paz-Ares. I'm a medical oncologist working at the 12th of October University Hospital in Madrid. I'm mainly doing with lung cancer in terms of patient care, but also clinical and translational research. And over the next few minutes, I'm going to try to review some of the issues in terms of relevant new data sets and advances during the last year in terms of immunotherapy and other non-targeted approaches in lung cancer in 2022. You see here my disclosures. And the way I have organized this is in three different sections. One dedicated to early stage non-small cell lung cancer, second one on unresectable disease, stage 3, and finally we will have the review of small cell lung cancer. In terms of early stage, we have a number of very relevant studies last year. And I would say, thank goodness, the advances we have seen with immunotherapy over the last decade has reached early stage over the last couple of years. And indeed, I think one of the most relevant data were on the Checkmate 816 study. You see here the design that was dedicated to early stage non-small cell lung cancer, stage 1B to stage 3A, following the TNM 7th edition, good PS, and no genomic aberrations that are suitable for TKI treatment. Patients were stratified by stage and PD-L1 and gender, and were given standard of care chemotherapy or the experimental arm, 3 courses of chemotherapy plus nivolumab. Then patients underwent surgery, and finally, after surgery, the patients could receive optional adjuvant chemotherapy or radiotherapy. Primary endpoint were dual pathological complete response and event-free survival. Here you see the main data out of this trial. There was a clear improvement in the pathological complete response rate from 2.2% on the chemotherapy arm as compared to 24% on the chemo plus nivolumab arm. The other primary endpoint, event-free survival, was also in favor to the experimental arm. You see here a hazard ratio of 0.63. That means a decrease in the progression rate of 37% all along the study period so far. That was statistically significant. And the immature data on survival suggest a numerical increase with a hazard ratio of 0.57. Of course, due to the immaturity, this data cannot be seen as statistically significant because they didn't reach the statistical significance. Important, last year was presented some data on the outcome depending on the response. And as you see here, regardless the treatment arm, those patients that reach a complete pathological response on the chemo plus nivo arm or in the chemo arm, they really had a very nice outcome. Very few patients relapsed. And of course, even among those patients with some residual viable tumor, the lower the viable tumor at the time of surgery, the better the outcome. And for those patients with plenty of viable tumor at the time of surgery, those were the patients that doing the worst. And I think that's pretty important data because that maybe is going to translate or what to do in terms of adjuvant therapy at some point. Some other relevant data are coming in the adjuvant setting. And here we have data from the IMpower010 study and the PEARLS study. This study with atezolizumab included patients from stage 1B to 3A, were treated after surgery, after complete resection with standard of care chemotherapy, and then randomized to receive atezolizumab versus best supportive care. And importantly, patients were stratified depending on gender, stage, histology, and PD-L1 expression. In the ITT population, that was patients with a stage 2 and 3A with more than 1% expression of PD-L1, there was a clear improvement in disease-free survival, and you see here that was very clear. That significant improvement in disease-free survival was also seen among all patients with stage 2 and 3A, regardless the expression of PD-L1. Even the magnitude of the effect was, of course, decreased, was not 0.66, but in that case was somehow decreased, as you see here in this slide, to 0.79. And the trial was not positive for the entire ITT population, those patients between stage 1A to 3A. So relevantly, the trial was positive, but particularly for the population of patients that were PD-L1 positive. Indeed, doing the analysis by the strata of PD-L1 expression, I have to say that most of the benefit were for those patients that were PD-L1 more than 50%. The hazard ratio in this very subset of patients was 0.42. And indeed, some of the agencies, such as the European agency, approved the treatment for that very indication. Last year, there were some presentation on the initial overall survival data. As you see here, there is a suggestion on those patients with stage 2 to 3A with more than 1% PD-L1 expression of some improvement in OS with a hazard ratio of 0.71. That was not statistically significant, as you see here, as the confidence interval is crossing the unity. When the analysis was performed on the population where the disease-free survival was clearly superior, those patients with PD-L1 expression more than 50%, you see here in this ad hoc analysis a much better hazard ratio, 0.42, suggesting that the magnitude of the improvement with adjuvant atezolizumab is related to the PD-L1 expression in the tumor cells. The other trial that was very similar in design is the Keynote-091 or the PELSIS trial. The only difference, I would say, in that case, the immunotherapy treatment was pembrolizumab. The second relevant thing was that patients were not necessarily required to receive adjuvant chemotherapy before entering into the study. Indeed, some 15% of the patients were not given chemotherapy because the patient was unfit or the physician considered was not indicated. And relevantly as well, the study was placebo-controlled. Again, importantly, the dual primary endpoints were DFS in the overall population and in the PD-L1 more than 50%. And as you see here, there was very similar results in the overall population, hazard ratio of 0.76 in favor of patients treated with pembrolizumab as compared to placebo in terms of disease-free survival. That, however, did not translate into an improvement in the subset of patients with PD-L1 more than 50%. And I would say that was somehow not validating what is being found on the atezolizumab trial.
Just a quick question. What's triple blind? The trial design said triple blind. I've never heard of that. What is it?
Yeah, I think it's also the sponsor being triple blind. It's kind of, a bit overdoing it, to be honest.
Got it. Okay. Yeah, no, I was just trying to figure it out. No, but that makes sense. That's interesting, though. Okay, please continue. Sorry.
Okay, so nowadays, then it is important to say that we have data suggesting adjuvant immunotherapy with PD-1, PD-L1 inhibitors do have some efficacy. The same is true in terms of the neoadjuvant treatment with chemo plus nivolumab. So the question is, what should we do with our patients? Should we use neoadjuvant chemo IO? Should we use adjuvant IO? Or should we use perioperative treatment, let's say neoadjuvant immunotherapy plus adjuvant immunotherapy? Well, there are a number of trials that are actually designed in this setting using immunotherapy in the neoadjuvant phase, in the induction phase, plus some adjuvant treatment. And you see here a number of studies. Indeed, the only study that didn't have a mandatory immunotherapy phase on the adjuvant setting was the Checkmate A16 that commented before. And we have 2 trials out of these other 6 trials that already we have some press release suggesting they are positive. Still, we do not have much data about the magnitude of the benefit. Those are the Aegean trial, starting chemo plus durvalumab, followed by durvalumab after surgery, or the Keynote 671, where pembrolizumab is added to chemotherapy in the neoadjuvant setting and then given on the adjuvant period. There is an extra trial that had a similar design, is the Spanish NADIM trial. In that case, patients with locally advanced disease, stage 3A and stage 3B, following the 8th TNM classification, were randomized to receive chemotherapy 3 cycles versus chemo plus nivolumab. And then patient was submitted to surgery, and then there were some 6 months of extra adjuvant nivolumab or no further treatment on the control arm. As you see here, there was a clear improvement in the terms of the pathological CR rate, as we have seen before in the 816 trial. Also, the surgical outcomes were much better. Particularly, look at the data. The number of patients that underwent definitive surgery were 93% on the chemo plus nivo versus 69% on the chemotherapy alone arm. Remember, those patients were stage 3A and stage 3B, not stage 1, not stage 2. The second thing is more than 40% of the patients in this trial had N2 disease in more than 1 station. So that means very relevant population. Importantly, PFS and OS were also in favor of the immunotherapy arms. So those patients treated with neoadjuvant chemo plus nivo followed by adjuvant nivolumab for 6 months had a better event-free survival with a hazard ratio of 0.48, and the same data were replicated in terms of survival, as you see here on those data that are now to be published in the New England Journal of Medicine. So, messages to take home in terms of early stage. I think neoadjuvant chemo-IO have shown to improve pathological complete responses, event-free survival, and overall survival in early stage resectable non-small cell lung cancer. After pathological CR, those patients are doing pretty well, and we are not sure those patients are needing the therapy in the adjuvant setting. However, we haven't seen much data comparing the addition of immunotherapy in the adjuvant setting or not. Adjuvant immunotherapy with a tissue and pembrolizumab also have shown to decrease the probability of relapse. It seems to be that decrease in relapse rate related to PD-L1 expression, at least in the atezolizumab trial. That was not the case on the pembrolizumab data. And secondly, the atezo trial is a bit more mature and suggests a numerical improvement in overall survival, but data still need to mature further before we have statistical significance. Finally, we have data on the NADIM trial and 2 press releases on the Aegean and Keynote 671 trial suggesting that perioperative neoadjuvant plus adjuvant immunotherapy with pembrolizumab, nivolumab, and durvalumab improve outcomes in resectable disease. I think we are awaiting those data, and then we may have an idea which patients are required to have only neoadjuvant therapy, which patients are required to have adjuvant therapy, and which patients are maybe benefiting from neoadjuvant plus adjuvant immunotherapy.
Could you help me kind of understand the 2 major adjuvant trials that we have right now? and from a practical, sort of putting aside reimbursement issues, how you would take those two data, or how would you like to take these two data sets and apply them clinically outside a protocol setting, and in particular, which IO and which situation? Because frankly, to me, it's pretty confusing.
To be honest, I think the main result of the two trials are superimpossible. They decrease in the range of 30% the risk of relapse in the population of patients studied. And that is the main message, very consistent. Pembrolizumab and atezolizumab. The main difference was that the benefit was clear for patients with stage 1B as well in the pembrolizumab arm trial, and was restricted to patients with stage 2 and 3 PD-L1 expressors on the atezolizumab arm. Indeed, in the atezo trial, the benefit was proportional to the expression level, and this is very consistent with what we have seen in other trials in the stage 3 and stage 4. In that sense, the pembrolizumab data is a bit of an outlier, and looking carefully at the data, those patients with high PD-L1 expression treated on the placebo arm had somehow overperforming as compared to what was expected. But of course, this is just a post-hoc interpretation of the data. So today, in my clinic, I think you can use Pembro, you can use atezo. The data for high expressors in the trial looks a bit better, of course, for atezo, and maybe for some people that is a good reason to use atezolizumab in high expressors. On the contrary, for stage 1B, for example, only pembrolizumab was having positive data, and only that subset was approved by the agency. So you could choose to do pembrolizumab maybe on those patients, I would say.
Do you think that when you look at these data, like one of the things that would come to mind would be difference in methodology of measuring PD-1? Do you think that part of what you see as a difference is maybe if you had taken all the specimens from one trial and had them tested in the other trial, that really the big difference was in PD-1 assays?
Honestly, not, because, it is true that in the Empower trial, they were using a different assay as a stratification factor, but the final analysis was done using, I would say, a standard assay, quite similar. So I don't think that should be the problem. On the other hand, the data we saw regarding the magnitude of the benefit being proportional, being relative to the PD-L1 expression, is something that we have seen in the advanced setting. Makes all the sense. So I don't think the PD-L1 assay is the main reason for some differences in the results among the two trials.
Do you think there's any inherent difference in the two agents? Is there any data either in lung cancer? I mean, to me, almost everything I've seen with Pembro and Atezo, it's pretty hard to separate. Do you think they're intrinsically different, or do you think maybe it was the way the trials were done?
Honestly, I don't have clear data suggesting they are very different. If it's true, it is true that pembrolizumab is targeting the PD-1 receptor, and atezolizumab is targeting the ligand. In some circumstances, the results are very similar. In some others, there were also differences in terms of the magnitude of the benefit. For example, in stage 4 disease, some trials look a bit better, or the magnitude of the benefit being better on the Pembro trials as compared to the atezo. However, I must say There were differences in the design of the trial. There were differences in patient selection, and maybe those reasons were behind the difference in magnitude of outcome. So I would say I cannot say at this stage one agent is better to the other, to be honest.
So, I was thinking about there are a couple of trials, adjuvant and bladder, one with atezo that was negative, one with nivo that was positive. And you maybe know Tom Powles, who's a investigator.
Absolutely.
He was the head of the atezo trial, and he went back and looked at cell-free DNA, and then he saw the benefit in the positive patients. I think that they've looked at cell-free DNA in the Empower study. What about the Pearls trial?
So at present, we didn't look as yet. We have some samples, and those are some of the studies that are pending. In terms of the Empower trial, those patients with ctDNA positive, with minimal residual disease persistent after surgery, they did worse and they benefit, but also ctDNA negative patients benefited from atezo. So that suggests that ctDNA, with the assay they use, is prognostic, but maybe not clearly predictive, because also those patients that were ctDNA negative, they were benefiting. And indeed, I have to say that maybe into the future, we have to improve the sensitivity of those tests so that we have less false negatives.
So yeah, I'm looking forward to the webinar and hearing you and Heather talk a little bit more about it. But again, when you sort of take a step back and look at this, I guess, I don't know, to me, the thing that I really have a hard time understanding, am I right in saying, like, in the Pembro study, did you not see benefit in high PD-1 patients?
Yes, that is totally true. We didn't see that. We didn't see that. This is very strange. If you look at the data, you realize that the main observation, after looking carefully on the distribution of other factors, the only thing we found was that, what was expected was that those patients on the placebo arm, among the high expressors, they should have done worse as compared to the overall population in the placebo arm. And actually, they did better. Even they are a worse prognosis, because PD-L1 high is worse prognosis in early stage. So the expectation would have been that those patients in the placebo arm did worse. So is that hazard? Is that any other thing? We don't know. But it's clear that those patients on the placebo arm here, they did overperform. And that is the issue. Look at this, 18 months PFS rate is 70% among the PD-L1 highs, and it was only 64%. And that is the reason the trial is not positive. It's not the efficacy of the Pembro arm, it's the performing of the placebo arm. But of course, those are post-hoc speculations, and we cannot be sure about that.
I'm trying to remember, I feel like there's been some data looking at response to chemo or benefits of chemo based just on PD-1 levels. Do we know that?
Yes. Yeah. I would say very consistent data suggests in second line and in first line, the higher the expression, the higher the probability of benefit, the higher the magnitude of the benefit. That is very consistent, no doubt, in stage 4 and stage 3.
Could it be lack of numbers? I'm just looking to see what the ends are for not plenty of numbers. No.
Yeah. That is also, that is one of the reasons when you have small numbers, your control arm is not behaving as the population because it's a small data set.
Really interesting. All right, please continue.
Okay, I think we are done with that. So if you're okay, I'm going to go with the second set of patients. So in terms of the second section, which is concerning unresectable stage 3 disease, we also have a number of interesting data. This first one is related to the Pacific study. You may remember that was a study dedicated to stage 3 unresectable non-small cell lung cancer that did not progress after chemoradiation. At this stage, those patients were actually randomized within the next 6 weeks to have consolidation therapy with durvalumab or placebo. And that was for a year, and PFS and OS were the co-primary endpoints. Now we have the data on the 5 years outcome. And as you see, there was a clear improvement in PFS, but also in OS. That translates into an improvement in 5 years OS from 33% to 43% on the durvalumab arm, an improvement in PFS at 5 years between 19% with placebo versus 33% with a durvalumab. That means a very consistent improvement in the long term, and that suggests we are really curing nearly as much as twice the number of patients. Look at the PFS at 5 years, 90% as compared to 33%. Important, a secondary analysis by Dr. Senna suggested that the benefit is true not only for those patients that were locally advanced because of N2 disease, stage 3A, but also for all of the other patients. So the benefit is quite there in terms of PFS for these two distinct type of stage patients. Importantly, we have also the results of the Pacific 6 trial. That trial was designed for those patients that were not good candidates for concurrent chemoradiation. So those patients were typically treated in the clinical practice with sequential chemotherapy and then radiotherapy. And in those patients, durvalumab was also given as a consolidation. And this trial that was not randomized, as you see here, suggested that this is a reasonable approach as well for those patients not candidates for concurrent chemoradiation. You see here PFS at 12 months, nearly 50%, and survival at 1 year is exceeding 84%. So those data, I would say, are pretty reasonable. Safety profile was quite favorable in this subset as well, and that somehow validates the use of sequential chemoradiotherapy followed by durvalumab for those patients. Also, we have another interesting data set, which is coming for the real-life Pacific study, which means patients that in the context of a real-world data study were given durvalumab after the chemoradiation concurrent and sequential. And as you see here, the data were pretty good. Look at that. 3-year survivorship, 65% or 58% for patients that receive concurrent chemoradiation or sequential. Of course, patients with high PD-L1 were doing better as compared to those patients that were negative PD-L1, 67 versus 54%. And it looks like those patients that initiate durvalumab earlier than 6 weeks, they were doing better as compared to those patients that started a bit later. As a potential improvement into the future, we have the result of the COAST phase 2 study. In that case, the same patient population of stage 3 patients with locally advanced unresectable disease, they were randomized to receive a standard of care, in that case, the Pacific regime, durvalumab, versus experimental arm A, durva plus a second agent, oleclumab, or arm B, which is another experimental arm, durva plus monalizumab. You see here that overall response rate was the primary endpoint and also PFS. You see here a clear improvement in PFS for those patients treated with the two experimental combination, durva plus oleclumab versus or durva plus monalizumab as compared to durva alone. I have to say, however, that in that very study, those patients treated with the Pacific regime with durvalumab were somehow underperforming as compared to the Pacific data. Look at here, median PFS is only 6.3 months. And you go a bit back to the initial data on the Pacific trial at 1 year, the PFS was, I would say, 67%. So I would say there is some underperforming, or at least that is some unexpected performing with durvalumab, and I think this should be taken into account. Anyway, those regimes, those immunotherapy combination regimes are now being studied on phase 3 trials dedicated to durva oleclumab and durva plus monalizumab, and data will tell us if this is a clear advance or not into the future. Again, we are also doing some studies with chemo, radio, immunotherapy concurrently from the beginning, instead of waiting to introduce immunotherapy after chemoradiation. They are trying to include it earlier on concurrent chemoradiation approaches, and data also should be ready soon into the near future.
Just kind of curious, kind of what we're going to do if, like the phase 2, the phase 3 shows both of them improved. How do you think people would react to that? And was there any thought about using both with durvalumab?
Well, the truth is that, I mean, the good thing is, I mean, honestly, both combos looks pretty good in terms of safety profile. So if they are good, I mean, you know, I understand that people would use the one that looks better. Even the trial is not set to compare the two experimental arms, but I suppose that in that case, safety profile would be important on top of the magnitude of the benefit of each combo. However, I mean, I think we have to be cautious. In that phase 2 trial, the two combos, they're doing a lot better as compared to the durva alone arm, but the durva alone were underperforming as compared to what we have seen on the Pacific trial. So we have to be cautious.
Any thoughts about why you see the difference here? You think it's just number of patients and random?
Well, I think the number of patients is very important. And then at this stage, it's really difficult to say for me if this is because only those patients in the control arm were bad patients or all patients were bad prognosis patients. You know, I didn't have the opportunity to have that in detail. During the study and during the discussion of this trial, they have done a number of statistical analysis trying to rule out patients on the durva arm had clearly poor prognosis as compared to the combos, but still, you know, maybe there are some uncovered prognostic factors that are not easy to highlight, to uncover.
Please continue.
Okay, so I think we are just at the time of summarizing the data on unresectable stage 3. I think durvalumab consolidation treatment, the Pacific regime, have a clear and remarkable long-term impact in unresectable stage 3 patient outcome. It is a clear improvement in 5-year PFS. That translates into a clear improvement in OS, 33% in the control arm as compared to 43% on the durvalumab arm. Those data had somehow been replicated on the real-world data on the Pacific R study. And of course, the consolidation durvalumab is also a reasonable strategy for those patients that are not candidates for concurrent chemoradiation, but to sequential approaches. I think into the future, there are a number of treatment optimization strategies that maybe include the use of consolidation treatment with combinations of immunotherapy. And the COAST trials show us that the combination of durva plus monalizumab or durva plus oleclumab may be reasonable approaches that should be studied. And indeed, they are being studied on the Pacific 9 study. But also concurrent chemoradiation immunotherapy approaches are also undergoing. Some phase 2 data have shown the feasibility of this strategy, and there are a number of phase 3 trials ongoing, including the Pacific 2 trial that should be reading in a few months or in the coming years. So you're fine. I will go for the last part of the presentation. The last section of this review is dedicated to small cell lung cancer. And I think here we have a number of relevant approaches as well. Over the last few years, we have seen data of chemotherapy plus PD-L1 or PD-1 inhibitors in the extensive stage setting, showing that chemoimmunotherapy combinations do improve outcomes, do improve OS, do improve PFS in this setting. Those were the data coming from the Empower 133 and Caspian trial. Over the last couple of years, we have seen some additional data. Some of them have been published last year, and that includes the Keynote 604, the Capstone 1, and the Astrum data. Altogether, as you see here, the hazard ratio were very consistent. The results were very consistent. Some of them, such as the pembrolizumab trial, didn't reach the statistical significance, but altogether, those data suggest very similar, clear improvement with a reduction in the rate of death between 20 to 40% in this very setting. Importantly, last year, we have also presented the data with the mature data with a follow-up of more than 3 years on the Caspian trial, and there was a clear improvement in survival for those patients receiving chemo plus durva as compared to those treated with durva alone. And as you see here, the separation of the curves is maintained over time, and at 3 years there are as much as triple the number of survivors, 6% as compared to 18%. That was not only true in the chemo plus durva arm, that was also true on the chemo plus durva plus treme arm. Indeed, the maintenance atezolizumab, some analysis of the Empower 133 trial showed that the maintenance phase is important. So part of the benefit, at least, is in survival and in PFS is due to the maintenance phase of atezolizumab during this study. In terms of the second-line setting, there are a number of trials that were presented last year. One that I really like to highlight is the Atlantis trial. That was for patients that had received at least one chemotherapy line and maybe some additional biological lines, and this trial immunotherapy treatments. And patients were treated with a standard of care, topotecan or CAV combination chemotherapy versus experimental arm, a combination of lurbinectedin plus doxorubicin. This regime was coming from an initial phase 1 trial with encouraging data. The primary endpoint was OS in this study, and you see here that there was no survival benefit. The curves were really super impossible on the experimental arm, lurbe plus doxo, as compared to the standard chemotherapy treatment, topotecan and CIV. There was somehow improvement in PFS that at least at the median was not very clinically relevant. We have done a number of other trials combining lurbinectidine with other agents. There was a prior presentation suggesting that the combination with irinotecan may be more effective and associated with reasonable toxicity, responses in some 62% of the relapsing patients. And last year, we also present this data with the phase 1 trial of lurbe plus atezolizumab. Full doses of the single agents, lurbinectidine and atezo, were actually feasible to be given together with GCSF. And among the initial 21 patient responses were seen in some 58% of the patients, including some 8% complete responses. There was a similar trial in terms of design, combining lurbinectidine not with atezo but with pembrolizumab. The initial data also suggests that full doses of the single agents are feasible, and among the initial patients treated in this trial, responses were seen in some 30% of the cases, and toxicities that we saw were quite favorable. What you expect in terms of the toxicities associated to pembro plus those associated with lurbinectidine without new signals. Have to say that this stage there is a phase 3 trial comparing in the maintenance setting for patients with extensive stage the treatment with atezolizumab versus atezo plus lurbe as maintenance therapy for those patients that had a response or disease stabilization after 4 courses of chemotherapy plus atezolizumab induction therapy. The final data we have relapsing disease are concerning 2 new agents. The first one is the BiTE tarlatamab. This is a bispecific drug that is binding DLL3, a molecule in the surface of small cell lung cancer, very highly expressed, some 85 to 90% of the cases. That protein, which is a Notch ligand, is typically expressed in the cytoplasm on normal cells, but is expressed on the surface of the small cell lung cancer cells, and is a very attractive molecule for this type of approaches using BiTEs. On the other side, on the other extreme, this bispecific drug is binding CD3 on the T cells and is inducing the activation of the T cell that at the end is provoking the lysis of the small cell lung cancer cells. The initial data that had been just published a few months ago on JCO suggested that the drug is tolerable. Half of the patients are actually developing some CRS, typically grade 1 or 2. Only 1 case of grade 3 was observed in this phase 1 trial. Some significant number of patients, about 40%, also had some neurotoxicity. For most of the cases was transient, and that typically happens, CRS and neurotoxicity, in the initial cycles. Importantly, responses were seen in some more than 23% of the patients, and more importantly, responses were somehow long-lasting. Median duration of response was exceeding 1 year, and indeed, you look at the data on PFS and particularly on OS, they are pretty relevant. Look at that median OS, 13.2 months. You look at any data set in the second or third line setting, most of the median survivals are in the range of 8 to 9 months, and I think this is somehow encouraging. The other drug I really like to highlight here is this antibody drug conjugate, DS-7300, which is targeting B7-H3, which is pretty much expressed in a number of tumors, including small cell lung cancer. In the initial phase 1 trial, responses were seen in a number of tumors, as you see here. Specifically, in terms of lung cancer, small cell lung cancer, 19 patients were treated, and at the time of the report at ESMO, some 59% of them, 11 out of 19 patients, did have a response. And actually, you see here, the profile of the duration of response seems to be quite reasonable as well, quite encouraging. And I feel further cohorts of are being treated with this drug, and also some combination trials are being started. So just let me summarize the data on small cell lung cancer. I think at the current stage, platinum etoposide plus a PD-1 or a PD-L1 blockade represent the standard of care in frontline small cell lung cancer. There are at least 5 trials that have shown very consistent data. Important, the impact is also maintained in the long term. 3-year survivorship on the Caspian trial is improved from 6% to 18%. And I have to say there were at last some encouraging data, at least preliminary data, with a number of approaches in the relapse setting. And I like to include here a number of studies with lurbinectedin, particularly in combination with immunotherapy, atezolizumab or pembrolizumab, but not, of course, with doxorubicin. As we have said, the Atlantis trial was negative. Other strategies that merit further attention, I think, are the T-cell engagers against DLL3, such as the case for tarlatamab, and the antibody drug conjugates DS-7300.
So just a couple of follow-up questions. First of all, in terms of lurbinectedin, did the Atlantis trial in any way discourage you from using lurbinectedin as a single agent in your practice?
Honestly, I don't think so. This trial showed that using lurbinectedin in combination with doxorubicin is not improving outcome. Actually, it's better. The safety profile is better as compared to standard of care, but it's not improving efficacy. However, in this trial, we are not sure we have used the right combination. Lurbinectedin was used at 2 milligrams per square meter, and we are not sure about the value of adding doxorubicin. A sub-analysis of that trial suggested that the use of higher dose may be better, at least that was a sub-analysis. And this is consistent with the data we have in the second and third line setting. Indeed, we have performed a couple of small phase 2 trials combining lurbinectedin with irinotecan and lurbinectedin with atezolizumab, and using lurbinectedin at the monotherapy dose, 3.2 milligrams per square meter, the data were pretty encouraging. Of course, early data, small subset of patients, but I think this is more likely the way to go.
So another question about these last 2 agents that you talked about, the bispecific and antibody drug conjugate. To me, I look at that and go, wow, that's pretty impressive. Do you feel that way? I mean, you're seeing objective responses there in small cell, it seems. I mean, and also, I don't remember, I mean, you have something like amivantamab that technically is a bispecific, but in terms of an immune bispecific, I'm not sure I've heard about solid tumors even having objective responses. You tell me, I don't know.
You're totally right. I mean, in terms of a T-cell engager, which is a specific, let's say, a very singular type of bispecific, this is the first bispecific T-cell engager that is working clearly in solid tumors. We have data with some BiTEs, blinatumomab, for example, in working in T-cell leukemia, T-cell lymphomas. and some data as well, some other bites in multiple myeloma. But this is the first encouraging data, I could say, at least for me, in solid tumors. The more important thing is that the duration of response is pretty good, and indeed, median survival in this cohort of patients in the initial phase 1 trial was exceeding 13 months. And I think that is very something in small cell lung cancer.
Yeah, I mean, in myeloma, you have one approved, teclistamab. In lymphoma, I think it's mosunetuzumab is approved also, I think.
Yeah.
And they're dealing with the whole issue of are docs in community practice going to be able to give it, et cetera. Theoretically, what do you think about this agent? Is the CRS and all, difficult enough that it's going to start out in tertiary centers?
So the truth is that I think at least for the initial studies, we have to be very cautious. I mean, we didn't have major issues in most of the patients in this trial, but we were admitting those patients for a number of the initial infusions. And those trials were done on a number of few dedicated centers. So I think the next step going into the community has to be done with caution as well, because I mean, it is important that those patients do have CRS. For most of the time, it has been grade 1 or 2, but of course, it requires knowledge, attention, and early treatment with steroids, fluids, tocilizumab, and so on.
Yeah, my favorite story about bispecifics is we did a program where I actually interviewed some patients, and I actually interviewed a patient who'd been on the bispecific for myeloma for 1.5 years, doing great the day that it was approved.
Oh,
so he'd already been on it for 1.5 years, and I use that as an example of the advantage of participation in clinical trials.
Honestly, I got in this program a good number of patients treated, and thank goodness a number of them really had a great benefit. Doesn't mean every single patient really responded at all. I mean, response rate was 23%, but responses are of pretty good quality most of the time.
If you had to guess your best case scenario, when do you think either one of these agents might become available?
Well, I don't know, but my guess would be that there is a clear unmet need on the relapsing setting for small cell lung cancer. So looking at the data, I could say it's very likely that the drug is going to be maybe approved on a fast track. I'm pretty sure that the agencies are going to be concerned about the CRS and so on. So I suppose that they are going to be very vigilant where and how those patients are treated. Indeed, the sponsor is very careful about that as well, because they are now starting to think about phase 3 trials, and I suppose they have to plan that very carefully, because those toxicities here require some really careful attention and specific knowledge on how to recognize them and early treat them.
Although the good news is that these docs are also, treating myeloma and lymphoma, and it sounds like similar issues. I don't even know if they have tocilizumab in the general office, but at least they have a couple-year lead on lung. So maybe by the time it gets approved, they're going to be a lot more used to that, I would think.
Yeah, absolutely.